Welcome to the Tria Health webinar. Today we'll be presenting Managing Mental Health During a Pandemic. Just a few housekeeping items. All lines will be muted, so please use the chat function. And at any time, if you have questions, please submit those questions so we can answer them at the end of the webinar. If you're also having any technical difficulties, please submit that in the chat function as well. Today we're going to be talking about mental health, and the exciting thing is that in the month of mental health, which is May, I'm very excited today to have a couple of presenters with me. My name is Jessica Lee. I'm the CEO of Tria Health, and I will be the moderator today. And I'm proud to have two amazingly talented pharmacists with me, Jason Grace, who's the Director of Clinical Services here at Tria Health, and Austin Morgan, who is one of our amazing pharmacists here at Tria Health. Just a quick background on Tria Health. Tria Health was founded in 2009, and we deliver pharmacist-led chronic condition management. It's really important to note that what we do is focus on optimizing medications, specifically with people who have chronic conditions. 50% of people don't take medications as prescribed. And in addition to that, people also don't get the outcomes they expect as well. By offering one-on-one consultations with pharmacists to optimize medication use, Tria is able to improve outcomes with individuals. One of the things that we've noted over the last 9 weeks with the impact of COVID-19 is the important role of the pharmacist for individuals who have chronic disease, particularly in this time when they are unable to visit the healthcare providers that they have in their lives. It's really important to ensure that they're managing their chronic diseases appropriately. That includes mental health as well. At this time, I'm going to hand the presentation over to Jason Grace so he can talk a little bit about what we're seeing in patients that we have worked with over the last 9 weeks, especially as it relates to mental health.
Well, thank you, Jessica, and thank you, everybody, for joining us here today. The past couple of months have certainly been a challenging time for anybody, and that really gets underscored for those patients and members who are dealing with mental health disorders at baseline. And so a lot of these common reactions to COVID-19 and the current pandemic really apply to anybody, but they are especially of concern in those with underlying depression, anxiety, or other mental health disorders. And so you just have members and patients who are concerned about how to protect themselves in doing everything they can to practice the habits that we know that can limit your exposure and risk of infection. And then there's just a lot of logistical issues that patients are dealing with right now in regards to access to healthcare, whether that be their providers, limitations and being able to get in for appointments and follow-ups, feeling socially isolated due to the recommendations at the national and state level, guilt for those that are dependent upon others for their health, and assistance in activities of daily living. And all of this is compounded for those that are already dealing with symptoms from depression and anxiety. In addition to the effects on those individuals, we certainly know that those that are in the workforce, that mental health can certainly impact their ability to function efficiently and productively at their job. Some information and stats that I'm sure will not be surprising to anybody, but if you look at some of the surveys that they have done, over half of respondents have said that they feel an increased amount of stress and anxiety over the past couple of months. And then breaking that down even further, individuals have responded that they're having difficulty concentrating, staying on task, procrastinating even within the workplace. And these are symptoms that feed into depression and anxiety. And, it is the final bullet point there on this particular slide does stress the importance of for workers feeling that they're they have support within the workplace, and that there are options available for them to deal with some of these challenges. And Tria Health certainly is a great resource and role for members and employees. So if you look at our model here at Tria Health, we utilize expert team of doctorate trained pharmacists who have also undergone postgraduate residencies and are board certified. And this is the team of clinicians we use for our patient care services. And we are really experts in the field of telehealth, which has become because of the challenges presented from COVID-19, has become a much highly utilized and route in which healthcare providers are trying to maintain connection and manage their patients through that mechanism. And that's something that we have a decade's worth of experience with in terms of engaging individuals, getting them connected with a clinical pharmacist who can really go through their entire medication history, go through their condition history, uncover and identify problems that they are having, and develop solutions for them to solve those problems and advocate for them on their behalf. And so with that, we really wanted to have an opportunity for this to be somewhat of a panel discussion and just respond to questions that patients have, give some insight into what Tria is doing for these patients and interactions that we've had. And so I'm going to turn it over to Jessica to moderate that discussion, and Austin and I can provide some responses and feedback.
Great. Thanks, Jason. I think we've got some questions submitted, but please continue to submit questions to us as we go throughout this panel discussion. So Austin, obviously you've seen and talked to a lot of patients over the course of the last 9 weeks. Can you describe what kinds of things you're seeing in terms of how this COVID-19 has affected your patients specifically?
Yeah, thanks, Jessica. And like Jason said, thanks everyone for being here to participate today. As Jason alluded to on that slide back there, COVID has impacted everybody in different ways, but particularly those with underlying mental health concerns or illness, with depression and anxiety. A lot of it ties back to just pressure and stress of the uncertainty here. Some specifics that people have talked to me about is the isolation. That's a really big one, of just feeling disconnected from support systems, family, friends, the normalcy of getting to see coworkers in the office with working from home, people being furloughed or laid off, unfortunately. So there's that component of financial security and insecurity, change in job security of not knowing what's going to happen next with everything in the economy. The uncertainty of information just about the disease. So how long is this going to last? What is the process going to look like to try to get back to normal? And just, how it's been kind of disjointed from a state level and a federal level, and just a lot of information for people to process and figure out. Having to parent and teach their kids with homeschool has been something that's been brought up from a lot of people, and how they've got to balance that differently now. So all of those types of things kind of have compounded on top of, underlying anxiety and depression in the first place. So we talked through it with them, try to help them understand, how to manage on their own, as well as what resources are available. And then kind of compounded with that we also work with other chronic health conditions too, right? So not only mental health, but diabetes, respiratory illness, heart disease, a lot of the things that have been highlighted in the news as risk factors for complications if you were to actually get sick, not just experience the stress and anxiety of it. So as kind of an example here, we had a patient who I talked with who, 37 years old, had severe asthma, as well as high blood pressure. So a couple of those risk factors that are listed out as possible complications. And when we're talking, she just sounds super short of breath, gasping for air. and we were discussing her asthma control, and she's using her rescue inhaler 23 times a day, which is just absolutely remarkable. Typically, if you're using it more than a couple times a week, that's a sign that your asthma might not be well controlled. So in her case, we talked what's going on here. She had a maintenance inhaler for prevention, but she couldn't afford it. So she was rationing the usage and then, trying to treat in between. And with some of the savings that she got with Tria, we were able to help make that inhaler affordable. But then in this current setting with COVID going on and her underlying really severe asthma, she was just terrified to leave the house. She didn't want to go out because of her risk factors, because she already couldn't breathe. She was worried about what might happen if I got sick. She had a 2-year-old at home, so she was concerned about their safety as well and bringing something back home. And it was really crippling to her. So not only did she have a barrier of affordability for inhaler, but she actually had a fear of going to the pharmacy to access it. So we were able to talk through options, got her actually set up with a mail order pharmacy called PillPack that was able to overnight her the inhaler once they received the paperwork and the prescription from her doctor, so we could get that barrier removed. And then kind of outside of medication, COVID's affecting just access to everything. We've all heard about the run on toilet paper and hand sanitizer. She was worried about going to the grocery store and didn't know about the delivery options that are out there. So we looked at what was available in her area, helped her get set up with either a Meijer grocery store or a Walmart or Instacart, so she could just even access daily essentials without having to leave the home and help quell some of that stress and anxiety.
So that's a great story, Austin. I mean, I think what we're seeing and what you're trying to illustrate here is that this is a person who maybe previously didn't have a clinical diagnosis of depression or even anxiety for that factor. So she's clearly exhibiting some symptoms that are, inhibiting her ability to control her chronic disease. That brings up something that I'm seeing in the questions here, and that's, can you talk a little bit about, maybe you and Jason talk a little bit about the diagnosis of depression, the diagnosis of anxiety, and then how that relates to maybe some situational types of behavior changes that we're seeing specifically in the severe time of stress. I think there's probably a lot of people right now that are experiencing some symptoms, and they're probably wondering, is this something that I need to be worried about or whatever? What are your thoughts about that from a depression clinically versus like a situational depression situation?
Yeah, and that was whenever I first started here many years ago, one of my pet peeves whenever I was working with patients was their understanding of their disease state. And so for depression, for example, it's unfortunately not an uncommon situation where a patient will be on treatment for depression, and whenever you ask them, why was this started? Give me the background. Let's understand what your history is. There may be situations where they describe, I went in to see my doctor. He asked me if I was depressed. I said yes, and he started a medication. That is not a setup for really understanding how depression is affecting their life. And what we're targeting treatment with is a simple, are you depressed? And so when we developed our depression care plan here at Tria, we exhaustively reviewed what are the assessment tools that will allow us to understand how depression is affecting each individual patient and how those symptoms, what are the highlighted symptoms that they are experiencing with a great degree of frequency. And so we have instituted, and we've had this in place for many years, we utilize the PHQ-9 questionnaire. There's a number of validated tools you can use to evaluate depression, essentially. But the PHQ-9 we found was the best fit for us, in that it really, when you go through that with a patient, you're really able, and it provides a lot of insight for the patient themselves to understand what are the symptoms of my depression that are affecting my daily life. And there's varying degrees of depression affects each individual patient differently. And there's patients who can have a number of symptoms from depression that they don't even recognize that that's the etiology of that particular symptom. And those are weighted a little bit different. I mean, depression is can be very different. The worst outcome you can see is from depression, to be honest, is self-harm. So suicidal ideations and suicidal attempts at self-harm. And those patients obviously are going to require prioritization, more follow-up in terms of because they have experienced those manifestations of depression. But other people in terms of ability to focus, fatigue, socially isolating, sleep disturbances, eating pattern disorders. These are all things that are associated and directly related to depression, and highlighting that for a patient. So we know it's important that the patient understands what we are trying to improve, not just, oh, you're not depressed anymore or your mood is better, but all of these factors that are impacting their daily life are improving on treatment, and making sure the patient understands what the timeline is towards symptom improvement, what are other resources and non-pharmacological things they can do to improve that. And so that's really how we approach it. Those are some of the tools that we use. And it's a lot of, in our world, it's a lot of education. It's a lot of improving health literacy and insight for the individuals to make sure that they understand how it affects them and how it can be improved.
So you utilize that PHQ-9 questionnaire to not only help the individual understand more about their symptomatology that they're having on a daily basis, but you're also helping to assess where they're at with their treatment.
Right.
Austin, tell me a little bit about what you would do if you had a patient who is experiencing symptoms of a depression, or even continuing to have symptoms despite being on treatment. What kinds of things are you doing for those individuals when you have someone who's maybe already being treated and still having symptoms?
Yeah, it's a good question, and it unfortunately comes up pretty regularly, because what we know from literature is that the initial treatment for depression or anxiety is often only successful about 50% of the time or so. This is one, it's not quite like blood pressure where we've got a med, it's going to lower the blood pressure in 90% of people. You just throw it on and it starts working. There's some trial and error involved in finding the right fit for medication in patients with depression and anxiety. So if we're talking through things and the patient, we go through that PHQ-9, they do score at a point where there's still moderate level disease or activity going on, and they're being bothered by the symptoms, et cetera. We'll talk through options. So gathering more of that history, where did we start at? How bad were your symptoms initially? What reduction has already occurred with the medication? What medication options have you tried in the past? What behavioral options have you tried in the past, or non-pharmacologic things as well? Discuss how long have you been using the medication. We do know that for depression specifically, it often takes at least 4, if not 8 to 12 weeks to be considered a full trial of medication at a treatment dose before you make adjustments. So, are they still having symptoms because they started the medication 2 weeks ago? And if that's the case, educating them, we need to probably stick the course for a little while longer, as long as things don't get dramatically worse, and then reassess at that, 8 to 12 week timeline. Now, if it's been months or years that they've been taking the medication and, if symptoms are still there, then it might be time to either do a dose increase or try a different medication or add something. I mean, sometimes just doing an adjunct medication on top can be useful to target a different pathway in the brain or in the body. So yeah, we would go through all of those things. There's a lot of history gathering, figuring out where someone's at, and then kind of tweaking things from there and making sure that they understand what to do.
It's interesting. I think my history, obviously, in my past life prior to Tria was I did some residency and training in psychiatric pharmacy, so this is kind of near and dear to my heart. And I think it's often common that patients mention, gosh, am I going to have to be on these drugs forever?
Right.
Do you find that question coming up, and what are your responses to those types of questions?
You know, we encounter that frequently, and almost even as common as that question is us addressing it with the individual. For those patients who were started on treatment in the setting of life events or stressors that occur at a certain point in time. So patients who perhaps have gone through a divorce or financial struggles or job loss or loss of a family member, and during that particular event, they were experiencing significant depressive symptoms. And we might be talking to them 3 years down the line during our initial visit with them. And as we gather that background and that history, and we discover that, that was the origin of whenever they started treatment, and now we are 2 or 3 years down the line, they potentially aren't experiencing any symptoms at all and haven't for some time. And then through that conversation, we discover that a lot of the inciting event was a particular situation in their life. And so a common conversation is, you might be a good candidate to consider a trial off of treatment. You don't have a repeated history of major depressive episodes. You're not currently experiencing any symptoms at all. And that is sometimes quite enlightening for the patient. You can get lulled into a belief that, well, I started this medication, I guess I'm on it for the rest of my life. And we certainly have numerous chronic conditions that do require lifelong treatment. This is not one of them. And there are situations that a trial off of therapy is more than appropriate when done in under the guise and under the guidance of your healthcare professional. And so titrating off of the medication and continued monitoring of symptoms is a conversation that we have every week with patients, and have overseen numerous patients who have been able to successfully stop treatment. That's
great. Just a reminder, continue to feel free to ask questions in the chat button, but Jason and Austin, I just got a really good question in the chat. Knowing what we know about depression and its significant impact on chronic conditions, how does Tria manage this?
So there's a couple of different things there. One is, yes, literature has certainly borne out that depression negatively impacts numerous chronic conditions such as diabetes, rheumatoid arthritis. From just a basic level of having a diagnosis of depression increases the likelihood of non-adherence. And so if you're not taking your medications, there's a greater chance or likelihood for having bad outcomes. And so we, through recognition of that, we do have a ability to screen patients for depression when they aren't meeting their goals for those chronic diseases. So if you have somebody with rheumatoid arthritis who has maybe been on appropriate treatment and has maybe failed a couple of, say, biologic agents, and there's no real other explanation for that, in the differential diagnosis of why this patient is not achieving their desired outcomes may be underlying depression that hasn't been identified. And so we can screen individuals. Now, this is not a diagnostic tool, but it's a PHQ-2 is a 2-question screening ability to identify if somebody should be evaluated for depression. And we have that built into our system, and it can be, utilized when appropriate. And we do use it in those types of scenarios. In addition to that, there's also the component of how does depression affect other chronic conditions? But then if you look at the patient as a whole, there's also the scenario of how does depression treatments themselves affect other comorbidities? And it just reminds me of one of the other pharmacists shared a story during our departmental meeting a couple of weeks ago, in which they had a depression patient who was on a combination of medications for depression. One of them happened to be a medication that's an atypical antipsychotic that's oftentimes used for augmentation in depression. Unfortunately, the other known factor with that particular treatment is it can worsen metabolic syndrome. So things like diabetes and cholesterol. This patient was struggling with those other comorbidities, and actually their depression was very stable. They were symptom free, and they had been on this particular combination for quite some time. And so that's almost the reverse of what I was describing earlier, where their depression treatment was actually, the actual treatment itself was worsening their diabetes and their high cholesterol. And she was able to, this particular pharmacist was able to contact their provider, who agreed to a trial off of the antipsychotic, which they have been able to successfully do, and that will result in an improvement of their other conditions. So it's looking at the patient as a whole. How can depression affect the comorbidities and vice versa? And that's something that we're kind of certainly skilled at and do on a daily basis.
Yeah, it's interesting how there's like a definite true pathological or something specific to the disease impact that depression can have, but also there's just that sort of psychosocial impact that taking medications and reminding, and that motivation factor also plays a role as well.
Right.
And now you're adding on a layer that maybe medications might have some role in impacting those chronic diseases as well. So obviously, a pharmacist is well suited to help understand that for that individual and find the right mix for them. So.
Absolutely. And it can be complicated, and it takes time to understand, each individual condition, how they interact with one another, and come up with a way to optimize their medication regimen to ensure outcomes are being achieved.
That's great. But, I think, Austin, tell me a little bit about, we've been talking a lot about medications, and I think a lot of times as pharmacists, we get sort of labeled as you're all about the medication stuff. But I know we've talked recently, and tell me a little bit more, Austin, about some of the non-pharmacological things that we're helping patients have access to or even try to practice outside of just medications for depression and anxiety.
Yeah, that's a great question. And it's super important to recognize that medication is not, and sometimes should not be, the only option available to someone dealing with mental health concerns. The data supports it. First-line treatment in many of these conditions can either be medication or behavioral therapy. And there's lots of nuances to that in terms of different things that a psychologist or a therapist or a counselor can provide. We have built into our care plans for depression and anxiety to do an assessment and basically screening patients and asking them, have you ever participated in cognitive behavioral therapy or any other sort of talk therapy or counseling in the past? Because it is so clear that not only are those successful in their own right, but when you combine them with medication, so a lot of times we're talking to these people because they're using meds for their depression or anxiety or otherwise, there's synergy, and they build on top of each other, and they can provide more together than perhaps either one by itself. So we try to broach the topic with people. I bring it up with every one of my patients to see if they've done it in the past, get their feelings on it, describe some of the pros and cons, and try to help them understand resources and access outside of kind of formal counseling and the like. There's the things that we all can do to try to help with our mood. And in the situation of COVID-19, a lot of people may not have, clinical depression or clinical generalized anxiety disorder, but they're feeling sad, or they're feeling hopeless, or they're feeling down or nervous or worrisome, which is a normal response to a global pandemic. So implementing some of the just good self-care behaviors, trying to maintain a schedule, trying to minimize or maybe compartmentalize their news and media intake to, certain quantities or times per day, trying to get outside. We've got all sorts of evidence that being outside in green spaces can improve your scores on PHQ-9 tests. Exercise, physical activity, getting in those habits. A lot of times that's one of the first things to go when you're depressed because you're not motivated. But it's kind of a slippery slope in this wheel. If you can get it going again, a lot of times it'll help improve your symptoms of depression as well. So trying to help people access those things, understand what habits they can put into place. And then if they need the more intensive counseling or behavioral therapy, breaking down barriers with that. So I had a patient actually kind of right in this wheelhouse just last week who is severe chronic pain, and he's got HIV underlying, so a little bit of a kind of stigmatized population that he's been dealing with for many, many years, and then severe depression. And he actually was referred to a specialist, a psychiatrist, started a bunch of those antipsychotic medications that Jason alluded to, responded very poorly to them, felt suicidal ideation, ended up tapering back off of them, but his depression was still there at baseline. And he was trying to access his EAP through his employer, but as we know right now, no one's seeing you in office, you can't get in to see anybody, and he was unfortunately kind of technologically challenged. He described it to me that this is the most isolated in his life he's ever felt because he didn't know how to use Zoom. When we were talking, he would have to call me back because his phone somehow got set on basically block all unknown callers. And he didn't know how to fix that, so he couldn't talk to anybody. And so as we were going through, he had an appointment scheduled with a therapist for his EAP in about 2 weeks. And later that afternoon, he told me, I'm actually planning to call and cancel it because they said they're going to do it virtually. I don't know how to use any of this stuff, and it's just not going to work. And so we talked about, I've actually found out who his provider was going to be through the EAP, put the patient on hold, called the provider. It was a direct line, which is uncommon, but fortunate in this situation.
Right.
The guy picks up, I kind of explain what's going on, find out they're going to just use, normal Zoom. He's going to send an invite link to the guy's email. I tell him, okay, we're going to try to figure out how to make this work. I'll get back to you with what we need. Get back with the patient, explain to him, how they're going to do everything, find out he does have an email address that he knows and can access. He can do that. But he's still like, I don't know how to use Zoom, which is what they were going to be doing the call over. And so he was more comfortable on his phone than on his laptop. So I had him download Zoom while we were on the phone, and then told him, let's set up a time next Monday, which was a week before his call was going to be. And I'm going to reach out to you, and we're going to do a test Zoom call, walk you through it, make sure you know how to use all this so you can get everything going. He's like, okay, great. So we got that scheduled, called his therapist back and got the email address. He's like, I'm going to send him a link right now to set up the appointment. And we should be good to go. Just a simple, you don't need to create an account, just click on it. I'm like, great. So call him back the next week and get him on the line. We were able to fix his phone situation so he can receive calls now from anybody. And then I sent him set up a Zoom call, sent him the invite, kind of explained, you literally just click the link, should go to the app. So we've got him on the line. He's on speakerphone, gets the link, opens it up. He's like, okay, I can't see anything. Can you see me? Can you hear me? I was like, okay, you need to tap the screen, go to it's going to pull up a little menu, select share video, and then boom, sure enough, he can see me, I can see him, and he's just like, whole face lit up, flabbergasted. He's like, this is unbelievable. I've never been able to do anything like this before. And so I was like, you're good to go, man. We've got you set up. He confirmed he got the email from the therapist, has the reminder set up on his alarm to, click it at the scheduled time. And he's like, I hope I can remember how to do this. And I was like, I'm going to email you step by step. So I got him like a 5-step process on how to make sure his video is sharing and how to access it and everything. So yeah, that was just a really unique and kind of cool, empowering situation. It had nothing to do with his medications. We talked about his medications and working with his provider to maybe find the right fit as an antidepressant for him. But it was more, very isolated, very situational, tied back to the pandemic, where working with a therapist would probably be best and helped him hopefully be able to do so.
Well, that's a great story, and I hope that Zoom doesn't decide to hire you as a help desk person or something. But I do think that illustrates like the the mission and values that we have here at Tria, that we're obviously here to help improve patient outcomes, and you definitely went the extra mile to ensure that that individual had what they needed. I really like the fact that you highlighted all of the non-pharmacological, like self-care things that we should all be doing. And I remember most when I was in my training and education that like sleep was like the #1 thing, that if you could get someone to get a good night's sleep, it sort of heals the brain, for lack of a better term, and makes everybody feel a lot better. So that's an awesome story.
Yeah, and I appreciate the story. It's so common whenever we have our weekly departmental meetings with the clinical pharmacists. A lot of our discussions and case studies that we share amongst the group are very similar to what Austin just described, and that we do call internally we call our program the Pharmacy Advocacy Program, and that's just a great example of the types of links that we will go to just make sure the patient's getting what they need. And so, yes, we are reviewing medications and identifying drug-related problems and recording and documenting those. But at the end of the day, it's what does the patient need? What barriers do they have? And how can we break them down? And that's just, we just have patients and case studies like that each and every week that we're discussing amongst ourselves. And that story really highlights that.
Great. Well, we have another question that's come in through the chat, so we'll have one more question I want to talk about, and then we'll probably wrap up for the day. But tell me a little bit, Austin. We kind of have talked a little bit about anxiety and depression. They're obviously tied to some extent, but can you help me differentiate a little bit symptoms between anxiety and symptoms between depression, and then like what that looks like for people? That we kind of have talked a little bit about that, but haven't gone into depth with that yet.
Yeah, there is often overlap. A lot of times people dealing with one will have certain symptoms of the other, but many times it can be a single diagnosis or one is more predominant. So we've highlighted a few things here for anxiety on like the validated questionnaires. The things that they're looking at more are nervousness, uncontrollable worry, feeling that you can't relax, you're restless, you're irritable or annoyed, fear that something awful might happen, and then assessing how does that impact your ability to interact with other people or do the things you want or need to do. Whereas on the depression side, it's kind of more tied to that feeling of down or hopelessness. And then like Jason alluded to, not always just feeling down or hopeless, but is it impacting your sleep? Are you falling asleep more often or difficulty getting to sleep or staying asleep? Is it impacting your eating habits, whether it's poor appetite or overeating, feeling bad about yourself or like you're a failure, difficulty concentrating, kind of coming back to that productivity. You just can't keep your mind on things that need to. Moving or speaking slowly. Restlessness can show up in depression too. And then there's really severe symptoms, like Jason mentioned, of feeling like you would be better off dead or wanting to hurt yourself would be a kind of hallmark severe depression type symptom. And they're treated and managed differently. The behavioral techniques that are used for them in counseling are a little bit different. And then certainly with medications, we've got first line treatment options that can work for both, but some of which for depression might be a little more stimulating. And if you have someone exhibiting behaviors of anxiety as well, you might not want to go to that as a first treatment option because it could worsen their anxiety. Some sudden or as needed treatment options for anxiety, things like Xanax or Ativan or Valium, those typically are not used at all in depression. They're short acting, they're not going to prevent anything, but in a situational position, it can be very effective to help calm somebody down. So it is important to delineate and differentiate what the symptom pattern is, how often it's happening, and it helps modify or tweak the treatment options to make it most personalized and give that individual patient the best chance for success.
Great. Yeah, so that's helpful. And I think obviously good targeted questions, helping understand people's baseline and where they are now is probably helpful to understand a little bit more about what they're going through. One thing that I think is interesting about anxiety symptoms, which I think is helpful to sort of mention, is sometimes those sort of manifest in really physical symptoms that people are having a hard time. They don't always recognize as anxiety.
Right.
Obviously, need to be sure that you're taking but can you talk a little bit about that, Jason? Like when someone has some anxiety symptoms, a lot of times we hear about chest pain. Obviously, if you have chest pain, we don't encourage you to not mess around with that and go to the ER. But what are some other kind of physical things you see when you have anxiety at the severest level?
I mean, you can have a number of different things, right? It's chest pain. You can have heart palpitations. You can have just general stomach upset, stomach pains, or diarrhea or vomiting. I mean, these are the physical manifestations of severe stress and anxiety. And certainly, if those are occurring, yes, you have to rule out other like cardiac causes or other things, but those would be certainly situations where treatment and maybe behavioral therapy is absolutely indicated because it's mimicking potentially more serious problems, but it also can confuse the picture to some degree. And if you can if anxiety and anxiety symptoms are the underlying etiology of those problems, then obviously you have to target your treatment and therapy toward the anxiety, and the waterfall effect of kind of curing all the physical manifestations that the patient is experiencing.
Yeah, I think it's interesting. Obviously, right now in the past 9 weeks with the pandemic, people are obviously more so who may not have ever been exposed to types of mental health changes experiencing those things. But the common theme that I'm hearing across us all is that depression and anxiety are tied into a lot of chronic diseases. We mentioned a lot of them, right? We've talked about heart disease. We've talked about diabetes. We've talked about pain. Pain's kind of come up quite a bit. There's obviously a lot of correlations between chronic disease and adequate treatment of mental health because we know it impacts their ability. So I think it's interesting. Do you feel like depression is and anxiety are something that's always been sort of prevalent and we're just now maybe becoming more aware, or do you feel like maybe that's a more prevalent thing in chronic disease specifically? And this is an opinion question.
Right.
I'm just asking, so.
Yeah, I mean, Austin and I can maybe both take a bit of a stab at this or give our opinion, but, I certainly think recognition of mental health in general has evolved over the last, decade or two. And certainly if you go back to, I think 50s and 60s, there was the stigma surrounding it has certainly fallen away to a great degree. Which means people aren't afraid to be honest if they are experiencing some of these symptoms. The old school way of just suck it up and deal with it is not as prevalent today as it was in the past. And so we are more aware of it. We're more likely, patients are more likely to at least be honest and answer questions about it to allow for discovery and diagnosis of underlying disorders. And so it allows to it's increased the ability to recognize it, to deal with it. And recently, just the multitude of studies that have shown the impact that it has on other conditions has clued providers and healthcare professionals into the importance of understanding it as a potential reason for why they're struggling with other comorbidities.
Yeah, I would agree that the stigma has changed. I don't think we're right where we want to be just yet. There's still a lot of undiagnosed. I think some of the more recent numbers I've heard are like 1 in 5 American adults likely have some sort of mental illness or mental health concern. So I don't think that 1 in 5 of everybody out there's broached that topic or has undergone treatment or whatnot for whatever reason. But I do think that the prevalence within chronic diseases is likely higher too. We think about the burden on a patient to manage diabetes or heart disease, or if they have a multitude of those things. It's very easy to get to the point where you're taking 5, 10, 15, 25 medications, that's a lot for anyone to manage, much less someone who is sick. And then you factor in all their doctor's visits. You know, if they're seeing a cardiologist and an endocrinologist and their primary care, and they got to draw labs, and then all these types of things, it's a lot of stress. If they're not quite meeting the goals of therapy, then there's the whole aspect of feeling down about that, like they're letting someone down, like they're letting their family down. You know, I encounter that very frequently with patients with diabetes who can't get their blood sugar to where maybe the guidelines say it's supposed to be, and trying to meet them where they're at, employ motivational interviewing, provide some inspiration and encouragement, meeting them, you know, small steps. How do we stop the ball rolling in one direction? Because that's the first point, and then maybe get it going in the other direction, and recognizing how mood plays a part in that, and the underlying stress. So I think that there's an interplay, but definitely many patients who are dealing with chronic illness are also going to probably be prone to this just from the stress of that condition itself.
Sure. Well, I think this has been a super informative discussion today. Do you guys have anything else you want to add as we close? Well, I appreciate Austin and Jason being here. This presentation is being recorded, so it will be available after today to be able to be reviewed again. And we thank you all for attending. And as always, we appreciate you supporting Tria Health. Have a great day.
Thanks all.
Thank you.